Dr. Susan Berry is going to be joining us to talk about Hope Happens Here, Understanding and Participating in Clinical Trials for Urea Cycle Disorders. Dr. Berry is a professor in the Division of Genetics and Metabolism at the University of Minnesota and current president of the Society of Inherited Metabolic Disorders. She has a long-standing interest in improving the care of UCD patients through early diagnosis and treatment. Dr. Berry. Oh, there she is, hidden in the lights. Please welcome Dr. Berry.
Try not to fall down and kill myself. There we go. All right, let's see here. What have I got to do? Okay. Well, just a word before I start on this, which is, you've heard a lot of really hardcore science here today, and this is not science that I'm going to be talking about. It's you and me as regular people trying to make complicated decisions. Second thing I'm going to mention is that, I don't know if even my UCD buddies know this, but I've spent a long phase of my career in active work in human subjects protection. That is, in investigational review boards, or what do you want? These are aspects for helping people make informed decisions about participation in research. And so it's particularly and acutely important to me that people are able to make informed decisions and understand what it means to be in a trial and what it doesn't. And so after all of the mRNAs and yeast therapies and all the things, I'm going to take it back a step and say, what does this mean to you as you're thinking about considering whether this is right for you or for your child? So what do we mean when we say we're going to do a clinical drug trial? So, boy, this is very tiny. Okay, all right. So a clinical drug trial is a research activity. It's research. That means we don't know how it's going to turn out. We want it to turn out the way we want to, but we don't know how it's going to turn out. Otherwise, it wouldn't be research. And what we want to know is if a new agent, a new medication is effective and if it's safe. Now, here's the tricky piece. There are actually 3 phases to investigation of use of a new agent or drug. And the first one is called phase 1. It's done in a fairly small group of people. And it's really to look just at safety and side effects, but it doesn't look at effectiveness. So if you're a participant in phase 1 of a trial, there's essentially no assurance of any kind that that agent will have any effect at all. And in fact, because they may be trying to figure out what the right dose is, you may participate at a level where even if the drug is ultimately effective, it's not effective for you. So people who are engaged in phase 1 trials need to do so with the understanding that they're doing it with the ultimate of altruism, because there's essentially no assurance of any kind that the agent will be effective at any of the doses that are used in a phase 1 trial. What I will tell you is in rare diseases, there are so few people that can participate in trials. It's very common, however, to kind of pull together what's referred to as phase 1 and phase 2. And in phase 2 trials, there's a little bit larger group, and at that point, they start to look at effectiveness, as well as having a much more concrete lens on safety of the agent. So a lot of times what you'll see is that it's a combined phase 1-2 trial. And you'll say, what the heck does that mean? What it means is that they're going to be looking at how much drug should be delivered, how safe it is, and if it's effective. Many of the trials that some of you, for some of you, I'm preaching to the converted. You've already been engaged in trials. And some of you participate in the phase 1-2 parts of these. But the third phase of studies are usually done with a larger group. And if you're doing a statin and there's 500 bazillion people who are going to take a statin, those groups have to be very large indeed when you're doing that. In a situation like those for the community that we're all part of here, it's a larger group is, instead of 3 or 4, it's 15 or 20 or 30. So what is it? The number of people that are engaged in a clinical trial depends to a large extent on the nature of the disorder, and with special rules invoked for rare disorders. So they've got you phase 1, really for safety and side effects. Phase 2 starts to look more at effectiveness as well as safety, and then phase 3 is ramping that up in terms of effectiveness, side effects. And ultimately, in some cases, comparison with similar treatments to prove that it's as effective or more effective than the original therapy you're trying to go with. So what would be the kinds of things that you need to think about whether you want to join or don't want to join a trial? Well, why be in a trial? And I think this is at the heart of most people when they want to engage in a trial. They have the potential for a treatment that could be helpful to them or to their child. So people want a treatment to be effective and helpful. The tricky piece, of course, of that is I have to keep reminding you is it may not be. That's what a trial is about. The second thing is that you may help others with the condition who need better treatments. That is the ultimate element of altruism in being engaged in a trial, is that you're not only helping yourself, but you're helping others as well. Now, why wouldn't you do it? Well, don't do it to please your doctor. This is something I have to emphasize, and in fact, when I myself, I'm putting on my other hat, I said I do an IRB hat, and then I have another hat where I've actually been the investigator working in a clinical trial. I don't want the patients that I care for to do the trial because they think I want them to. I don't want them to do the trial because they think it will please me. That is not why to do the trial. I'm grateful that you honor me with that kind of thinking, but that is not why you should do it. You should do it because you feel it's potential for treatment for yourself or you want to help others. You shouldn't do it to please your doctor. And for God's sake, don't do it if you don't want to do it. You don't have to say yes. You can hear the whole thing. And in fact, if you're in the middle of it, with the exception of gene therapies, once you've already gotten the agent, you can't undo it. If you don't want to continue in the trial, you don't need to. It is absolutely, and I can't emphasize this enough, it is absolutely voluntary that you participate in a trial. Absolutely voluntary. If you don't want to do it, you should not do it. And if you want to stop doing it, you should stop. Okay? I'm giving you official permission. I don't have to. That is something you should be able to do. All right, so a little bit about how trials work. And again, some of you have already done this and you're going, yeah. But many of you are new to this whole idea that you might have a treatment that would come through experimental interventions. And so, just so you know, sort of the bones and construction of it, trials actually have a sponsor. We typically think of that sponsor as being a drug company, and a lot of the trials that we're doing are headed through that kind of sponsorship. But you can, in fact, have a sponsor who is an individual who has a bright idea and somehow they figure out that they're going to do it. You can have an institution that has the wherewithal and ability to create it. It has to be a responsible individual who has a responsible sponsor who has someone who's identified as a principal investigator, the main person who's responsible for the thinking and the conduct of the trial. And what I would say is the buck always stops with the principal investigator. They are responsible for the actions and activities in the trial, and they're held to a very high standard for meeting those expectations. Now, typically, for almost all trials, you're going to have multiple sites. It's very difficult to do clinical trials in a single location, particularly for rare disease. It just doesn't happen because you're not going to have enough people to do them, no matter how you do it. Most trials require, with some very few exceptions, more than one person. And so you're going to have multiple sites. And each site has a person who, at that site, is responsible for the conduct of the trial. They have people to help them, they may have staff, they may have regulatory support specialists, they may have everything, but ultimately, at any given site, the individual who's the site investigator is responsible for following the rules and for doing a job. And it is really important that they realize the level of their responsibility and commitment that is to anyone else in the trial at their site. All right, so trials they can't just, you've learned that in some of our therapies, when we're treating you in clinic, we kind of fool around a little bit. We say, if this drug, the dose isn't quite right, well, we'll just crank it up a little bit. Or, are you getting enough protein? Well, maybe we'll give you a little bit more and see how it goes. You cannot do that in a clinical trial at all. They follow a very strict protocol that is exactly prescribed, and exceptions to the protocol, even trivial ones, need to be recounted and recorded. And so the protocol defines the goal of this study. It defines who is eligible to participate, who can be in the trial. And again, there are very strict criteria typically for that. It gives detail. It could be something like you have to get a test to see if you have the AAV antibody, and if you do, you can't be in it. That's an element of participation eligibility. But it might be you have to have a DNA test that proves you have the disorder you think you have. It might be we're only going to do this in adults and not in children, and we'll talk more about kids in this. It's a series of elements that say someone fits the criteria under which the testing is going to be undertaken. Now, the protocol talks about the tests and the procedures that are going to be taking place, the treatments that are going to be used, and they have to be prescribed in a lot of detail. The reason I mention all of this is that the protocol is something that's revealed to you, the participant, through documents that allow you to know what's going on in the procedures, and help you decide if you're willing to take the risks that are involved in it. So it has to describe the protections against the risks of the procedure, because there are risks to participation, there always are. It has to tell you how long you're going to be involved in it. It has to tell you what information is going to be gathered, how much tests you're going to have, when you're going to have those tests, why you're going to have those tests. I don't mention this because it doesn't appear in the protocol, but you should know, and one of the elements of the facts that go with your decision making is it going to cost you anything to be involved in the trial? I will tell you that in most cases, in clinical trials, the expenses are covered to a large degree, but there's always untold expenses. Or you have to fly 17 times? Well, even if they're paying for it, you have to take off work. You're going to have to harangue 2 or 3 small children through an airport all the time. There are costs that go beyond dollars and cents that have to be accounted for in your personal decision making about whether being in a trial is right for you. I want to go into a little bit more detail about human subjects protection. This is something I feel very strongly about, and I hope that you understand that people who are engaging in trials are utterly responsible for. And that is, every trial is evaluated for human subjects protection. So the IRB, the committee that does this, is made up of a prescribed population of individuals. There are scientists, there are non-scientists, so that there has to be on the committee that's evaluating, have to be regular people that don't know about science, and they're going to read about the trial, and then they're going to have to say, if this was me, how would I feel? As well as scientists who can look at it and say, scientifically this makes sense. They've got this organized well in terms of the numbers. They're going to learn the kinds of things they think they're going to learn from this trial. They has to have, there's a specific in-law constitution of what an IRB has to be made up of. This is regulated in federal regulation in the U.S. And when they consider what's going to be done in the trial, you have to decide, and these are the critical elements for deciding if the human subjects are protected. They have to see that risks are minimized. It does not mean there will be no risks. It means that the investigator has gone to every effort to minimize the risks that someone's going to be exposed to in doing a clinical trial. You have to have some assurance about the balance between risk and benefits. You have to know that there's at least a potential for benefit, or if not, that there are good reasons why you might not have that balance. You have to decide if it's fair. That is selection for this equitable? You have to make sure that people have equal access to the intervention, for example. You have to be very explicit when you're the investigator to describe how you are going to ask somebody if they're going to participate. And this is typically done through a written document that is sometimes referred to as an informed consent form. I don't like that title because how do you know it's informed? So I just call it a consent form. But it's actually a written document that you, the participant, will go through with an informed person who's going to tell you about the trial. And it recounts many of the things I've talked about here. It has to describe the nature of what's going to be done. It's going to describe what tests you're going to have to undergo. It's going to tell you what the risks of the intervention or the tests are. It's going to tell you how much it's going to cost. It's going to tell you who's going to pay for it. It's going to tell you what happens if something goes wrong and who pays for that. It tells you if you're going to learn information that could have problems, give you problems. For example, in genetic testing, it has to give you information about how that could impact your decision making. It's an involved process, not an event, to get fully informed consent. We have to talk about privacy and confidentiality. We have to talk about how safety will be monitored, and the people who are looking at the protocol and looking at the consent form have to make sure the protocol is reflected in the consent form and that the consent form is written in a way that the person who's looking at it and having explained to him can understand. The strict criteria for consent forms is that they should be readable at an 8th grade level. And I would tell you that is a very difficult task to accomplish when you're talking about gene therapy. You just heard, I'm sorry, Sean, that was not 8th grade level. But it was really good. It was a good description, and people were working hard to do that, to listen to that. But if you were trying to make a tough decision personally about being involved, you want it to be understandable. The person, you don't want somebody to do it just because it sounds fancy. You want them to do it because they understand what's being asked of them and that they freely agree that they want to take the risk of participation. So people strive for that 8th grade reading level. I will tell you it's not always accomplished, but it is, so you have a sense. Even 8th grade reading is pretty hard to ask for, right? That's a lot. All right. In this audience, I have to really emphasize the importance of thinking about children and research. I will preface this to say this also, the children are protected in research by federal regulation. There are exact rules that I'm going to briefly go through that frame the context in which children are protected in research. There are no such rules for vulnerable adults. And so different institutions have different degrees of rigor for protection of adults who can't make their own decisions. But to a large extent, many of them act, although I totally understand and do not mean that adults who do have impaired decision-making capacity are children. Some of the kinds of protection should be reflected in in the ways we protect children, so that you really have a higher standard of support for vulnerable adults. There are also special rules that I'm not going to go into detail about them, but that protect prisoners who can be engaged in research, but there are very strict rules for it. And for persons who are pregnant, that the rules govern the research in pregnant women and think about the risk to the woman and the fetus. And I'm going to focus on children because for a lot of us here, that's a big part of our questioning. And so that one of the rules about children is that children can't consent to research. That means their parents or their parent have to give permission. Children are also, however, asked typically to give assent. If the kid is old enough to understand what's going on with them, it's the expectation of the IRB that you will ask them if they want to be part of it, except for some very specific limitations. That is, if your child isn't really in a position where they can assent even if they're at that age, and there are certainly children who would not be able to understand or even think about how they'd be involved. And the other one is, if the treatment that's going to be applied can benefit your child, and it's only available in the context of this clinical trial, then you can inform the child, but parents can make a decision and essentially impose their decision-making on the child. But children, we really make every endeavor to help children be engaged in the process of thinking about their engagement in research. And what are some of those special protections for children, and kind of how do we think about them? And one of them is, and there are different levels of engagement. These are actually codified also in the federal regulations, and one of them is what the child will experience more than minimal risk. Now, if whatever you're gonna do in the clinical effort, in the research, is no more than minimal risk, that is, based on everyday life for that child, if they're not gonna experience anything they wouldn't experience in ordinary life, then there's a lot of flexibility in being able to engage the child in research. However, and it doesn't take much to go beyond minimal risk. For example, there's always a lot of argument about whether having a skin biopsy is minimal risk or not. That is not a very invasive or dangerous procedure, but it means that you have to inject Novocaine or something, and then you have to break the skin, and you have to hold the kid down. So it's not a lot more than minimal risk, but it's more than minimal risk. So it's a fairly low threshold for what minimal risk is. Now, if it's more than minimal risk, if there's a potential, you don't have to promise, and this is why you could engage a child in a phase 1 trial. There's the potential for direct benefit, though there's no guarantee that there will be. If there's potential for direct benefit, then we allow engagement of children in research with the permission of one parent. Now, and sometimes there's research that's undertaken where you can't be certain that there will be any potential for direct benefit to the child, but it's so important in understanding what's going on with the child's condition that it's maybe worthwhile to engage the child in research. And if there's generalizable knowledge about a condition under those circumstances, with the permission of both parents, the child can be engaged in research. Now, there's a final and very hard barrier to obtain. Occasionally, there's something that's so important to society, even if there is no direct benefit to the child, that's so important to the society that research should be undertaken. I think the only time I've heard this argued very extensively was when they were worried about smallpox reemerging. And they were thinking that it would be so important to the general well of society to reinvigorate the idea of smallpox vaccination that they might do this even when you would be doing this in normal children. It would be more than minimal risk. There might or might not be a direct benefit to those children, but it might benefit the entire society so much that maybe it should be considered. And there's actually a very complex and very rarely invoked procedure where you can do research at that level for children. In most cases, it really requires either benefit to the child, the potential for direct benefit to the child, or such important generalizable knowledge about their condition before they can be engaged in research. So special protections for children, it's held to a very high standard. I need you to know that because that means people really need to think, as they're thinking about research in children, whether it's gonna meet those barriers. And what you will find that means is that sometimes research has to be engaged in adults first, in adults who can make their own decisions. That doesn't seem fair because, for example, the most severe form of a condition may be happening in a baby, right? Yet you will find that the trials will begin in an adult with a milder form of disease who can make a decision, and that's because of these stringent and protective expectations about research in children. All right, well, Sean alluded to this a little bit, but I think it's really important for everyone to realize that being engaged in research is a commitment and it's a challenge because there may be unpleasant or serious or even life-threatening effects of experimental treatments. Cytokine storms, responses to viral injections, and so people may not, the intention for the clinical trials and the engagement in research is that it will benefit the person, but there are risks involved, and people need to know what they are. This may also require more time and attention than your standard treatment would. You might have to visit, I think you outlined that really well, so I'm not going to go into a lot of detail, Sean, because you may have to go to the study site. We've had people engaged in clinical trials who flew up to visit us in the Twin Cities from faraway states, twice a month for a year. That's a lot to ask people to do. That's a lot. I was incredibly grateful that they were willing to do it. They were wanting to do it because they thought and hoped that that would help their children. But it's a very big commitment. There may be more blood tests than you're used to having, and that's a lot to ask. For example, if you have a child that doesn't like to have their blood drawn. That can be a very big piece and difficult challenge in it. There are more procedures or hospital stays. And there may be complex dosage schedules that you're supposed to follow very carefully. And that's important in the context of the trial. So those are just examples of some of the things that may make it a real commitment to participate in research. So some things you should think about talking with your doctor when you're thinking about a trial. I would urge that this is probably true not just for trials, but sometimes if you're going to hear or have a conversation about something complex with your physician, and that is consider having someone or a friend, a family member or a friend come with you for another pair of ears to provide support, recording answers, giving you a chance to have someone else reflect with. That's always welcome in either a clinical or a research context from my point of view, and it can make a really big difference to have someone else's ears with you. It's often helpful, and this is also true in a clinical visit, to plan what you're going to ask in advance. I love it when someone comes with a list. It really makes it be that we can make sure we cover everything with everyone. But don't hesitate to go beyond your list. Ask whatever questions you need to assure that you understand what's going to be going on in that trial and what the impact will be on you or your child. So write down your questions, and then we love it when people do that. Sometimes I kind of go, oh my gosh, there were 5 pages, but you know what? That's okay. That's why we're there. You can write down the answers if it helps, but if it makes it easier for you if you want to process that way, it's always and it's totally okay for you to tape it. Particularly if it's a complex and difficult decision and you want to share it with someone else later and they couldn't come with you, none of us are going to object to that. You say, like, it seems I'm being really weird, I'm recording it, but there are sometimes when what you need for information and processing is more important than what people think about being recorded, okay? So that is certainly a permission that you should give yourself to get the information you need to make the best decision for you and your child. I thought about going into a lot of detail about the kind of nature of how you can have a trial set up, where you can have an agent that doesn't work, a placebo, and one that does. And I decided to stop at this point. But I'm happy to answer questions if people want more details in that direction. I thought it was more important to give you the sense of how much we value your participation in trials, what it means to us as investigators. We want to learn as much as you do for your child. We are not your child's parents. But we do care a lot, and we want to do this responsibly. And we owe that to you as people making these decisions. So I hope that I've given you kind of a flavor of some of the things we go through in trying to consider this, and I'm happy to answer any questions about it if people have more detailed questions. So that's enough for me. Thanks.